Greetings, class for Intro to Health Systems and Policy. I'm going to give you some background information this week about Chapter 5 from your textbook, talking about population health. So to get started, it's important to understand that healthcare is just one of many factors that contribute to physical and mental health of a population. One thing that we know from literature that there is many other factors that contribute to poor health outcomes and population health. Other determinants responsible for health or disease of a population include education, income, genetics, behaviors, environmental exposures, but we also know influences outside the healthcare system greatly affect which groups of people are more likely to become ill, injured, or even die early. These influences also help determine people's healthcare outcomes once they become sick, injured, or disabled. So it's important to understand the population health versus the medical model. When we look at the population health model, we are looking at, just as it says, a population. We're really looking at disease prevention, health promotion, and really looking at interventions that are focused on the environment and human behavior and really trying to prevent diseases from happening. Then when we look at the medical model, really looking more at the individual basis, looking at diagnosis, treatment, and intervention is typically the medical care. So oftentimes you may find that the medical model is addressing individuals after a disease has set in, and really when we're looking at the population health model, we're looking at the prevention side of things. So the population health model seeks to explain and intervene in the causes of the systematic differences between health in different groups. And these are things I'm sure you're learning about more in your classes, but we're really looking at the patterns, understanding the patterns or distribution of health between different groups of people in order to identify and understand factors that lead to differences in health outcomes. One of the things that has been in the literature and the research more and more is what we look at upstream causes. So those are factors that influence health through a series of pathways that we may not be always able to see. We also look at those as considered the determinants of health is used rather than factor or cause. Oftentimes you'll hear that determinants of health really impact our health outcomes more than healthcare and genetics combined. So the population health model is really looking at that systemic upstream issues. We also know that multiple determinants of health describe determinants that arise from really looking at 5 domains, specifically social and economic development. So when we're looking at that, it's income, education, employment. Social support is actually a really important indicator that's come around more and more lately. So we know that if folks have social support, they're going to have a better opportunity for positive health outcomes. Culture also plays a really big important part of this, and ultimately the social and economic environment is really those drivers of those determinants of health, and by and large our health outcomes nation and worldwide. We also know it's important to look at the physical environment. So for example, urban design, housing, we know housing issues pose a problem for poor or good health outcomes depending on where people live. We also know availability of food. In rural South Dakota, we know that there's a lot of food deserts, and even in urban areas, so access to healthy foods is certainly an important piece of prevention of diseases. Also looking at air and water safety, exposure to environmental toxins. Genetics and what we call epigenetics are also determinants of health, really looking at epigenetics is a study of gene-environment interactions. So how do our genetics interact with the environment that you all live, work, learn, and play in? Medical care, looking at prevention, treatment, and disease management. And then we also really look in public health at the health-related behaviors. And we know that's an important part of that population health model, looking at behaviors such as smoking, exercise or physical activity, what types of foods that we eat, and really that's focusing on that reverse causality with that population health model. You also see in your textbook a good figure that's talking about how determinants of population health interact and really ultimately contribute to the health outcomes. Understanding that individual behavior really is that starting in that lower rung. As we progress and move up the the line, you'll see that social, family, community networks, also living and working conditions, and how those all interplay really to look at that broad social, economic, and cultural, health and environmental conditions, and even policies at global, national, state, and local levels that can affect population health over the lifespan. So it's really complicated and detailed factors that affect our health outcomes. So when we look at the medical model, we know, again, that this focuses on individuals, tends to look more at that pathophysiology, and it's really looking at a reductionist model. So it looks for molecular physiological mechanisms that explain how specific factors may produce illness or act as markers of incipient disease. And I know some of a lot of the medical students may be focusing on these components in their studies as well. We also know the medical model attempts to find the silver bullet, for example, one that will stop or reverse those mechanisms or cure or prevent progression of a current medical problem. Medical models also frames risk factors as working through disease-specific pathways, analyzes risk factors as if they were independent in statistical modeling, and then also considers how biological systems within the individual interact. Again, we're looking at that individual level versus that population level. Medical model is as we talked earlier, healthcare is generally reactive, so it responds to abnormality or disease or injury. So a sickness care system, and really looking at more of that secondary and tertiary care after disease has already set in. Healthcare has traditionally been delivered and even reimbursed in acute episodes, so less value tends to be placed on and less reimbursement provided for efforts to promote health or to prevent illness and injury. Ultimately, we know from the research and the statistics out there that the chance for Americans to live long and healthy is not improving. And unfortunately, the United States spends a significant amount of money on healthcare, but we have some of the poorest health outcomes in the world. And you can look at medical model. It's also in your textbook in the screen, but again, this is showing you the association between health spending and life expectancy. And again, unfortunately, the United States spends the most, and we have some of the poorest health outcomes and low life expectancy. You'll see the United States far outspends a lot of the other developing countries as well. And this is really guided by that medical model as well. So, for example, if we want to look at the medical model and the population health model as it relates to obesity, the medical model, and really that may have providers who really look to focus on assessing that family history, diet, activity history, maybe laboratory tests, so really maybe ruling out hormonal or other physiological causes, check for other diseases that are comorbidities with obesity, such as diabetes, heart disease, and then really look at interventions such as referral to a nutritionist, perhaps diet, exercise prescription, and even bariatric surgery. Then when we look at obesity from the population health model, we're looking at, again, from that population level, focus on obesity epidemic. We may look at some other factors that contribute to poor health outcomes and what the research does support for obesity. So we know that race and income are risk factors for obesity, so those might be some opportunities to address obesity within those specific areas. Reasons for non-compliance, maybe it's looking at the environment. So zoning law changes so people can be active and physically active in their neighborhoods. They may not have safe neighborhoods to be physically active in, and so maybe it takes some policy to change some of those zoning laws. Menu labeling, that's something you're seeing a lot nationwide, and even with our restaurants. Those are things that are having to be required, and because of the growing epidemic with obesity. But we know that that policy piece can come into play with that population health model. Working with food industry to provide healthier options, which again, I think you're seeing more projection with that across the nation. Certainly more healthier options are being offered, I think, because of the demand and certainly the obesity epidemic. And then again, educational policies, encouraging healthy food choices, increased physical activity. You see a lot of that in the K through 12 school system. Certainly looking at policies that are within the food system program within the schools, requiring certain types of food be provided for students, so they have access to healthier food options, and then also maintaining that physical activity as part of that population health model. So those are really two different areas when you look at the prevention population health model side with obesity versus the medical model, which really is looking at that response. People are already struggling with that obesity and finding some different ways to address that. So comparing, again, those medical model and the population health model. So causes of obesity epidemic, when we look at that population health model, we talked about this in the last slide, but higher density of fast food restaurants in low-income neighborhoods, that's certainly a physical environment, food desert type per environment. Presence of vending machines in schools. So if they have unhealthy foods in those vending machines, we know that, kids have access to those. They may be consuming those. That may be their only opportunity to consume food throughout the day. And so if they're vending machines are present, and if vending machines are present have unhealthy foods, that certainly can play a role. Subsidized school lunches that are high in calories and fat. So again, that's where those policies come into play to help curtail some of those foods that are offered to kids in schools through policy. A decrease in physical education classes. We certainly know that's been something that's been happening nationwide is less requirements for the physical education, and sometimes even a near elimination of recess periods. We also see fewer people walking or bicycling, so we know that physical activity is certainly on the decline, and want to see that can be increased too. And some of that may be due to fewer safe places to play or walk, especially when you're looking at urban or low-income neighborhoods. Just because they want to be healthy doesn't mean they have the opportunity to be healthy, and they may not live in the safest area and can't really get outside to be physically active because they can't afford to go to, say, a gym or something like that, so their best source of activity is in their neighborhood. Lack of grocery stores with healthy food options. Again, if that's all you have access to, you're going to eat what you have access to. And if you're low income or maybe you don't have transportation, you're going to have less of an opportunity to access those healthy food options. And then we also see within advertisements anymore, marketing those high obese-ridden foods to children or obesogenic. So marketing to children that they want to have perhaps some of those unhealthier options as well. So those are a lot of the causes of the obesity epidemic when we look at that population health model. We also can look at what we call the root cause of a health outcome or a disease. So if we look at that specifically to obesity, an example is we know obesity, two of the factors that tend to contribute to obesity are physical inactivity and unhealthy nutrition intake. But we also have to look a little bit deeper and really think about that root cause. So just because somebody's physically inactive, there might be some other things that are supporting that. So perhaps lack of access to physical activity opportunities, unsafe neighborhood. If we look at unhealthy nutrition intake, again, they may live in a food desert, they don't have access to those healthy foods, or they may be in poverty, low income. So just because somebody is physically inactive and not eating healthy, those aren't typically the sole purpose of causes of what's contributing to that obesity. There may be a lot of those root causes. And so those are things that are really important when you think about social determinants of health and health outcomes, and even population health, is really what's that root cause. And again, we tend to look at those social determinants of health as really driving those root causes. Here's another example. We compared the medical and population health models in tobacco or tobacco use. Again, the medical model may focus on individuals who smoke or chew tobacco and really focus on that behavioral change. Cessation counseling, nicotine replacement options are certainly some good opportunity to help with reducing that tobacco use. And then when we look at the population health model, we're going to look at exploring influences of tobacco production. Advertising that influences tobacco use. Certainly know e-cigarettes are becoming more popular. Distribution and patterns of use by groups. Certainly see a lot of tobacco use for youth under the age of 18. Interventions when we focus on the population health model are, again, looking at policy. We look at those smoke-free laws, certainly look at tobacco taxes, and even regulation of advertising and marketing. And so a lot of that comes into play is that policy and legislation that can look at some of that as well. One thing to look at when we're looking at that population health approach is really what we call health equity. So making sure that everybody has access, equal opportunity to live healthy is really when we look at that health equity approach. Currently, you'll see to the left of your screen a lot of that current approach. So again, if we're looking at vulnerable populations, so individuals or populations who have more health disparities, lower chance of being healthier. So we tend to focus on people rather than institution or societal factors that generate risk. But if we want to look at that health equity approach, or really that population health approach, we need to look at those oppressed populations. So address those injustices in the everyday practice institution. Maybe there's some systemic issues that are causing that. Those traditions, laws, and rules that may be contributing to that. Another example is looking at lifestyle. So the current approach, you may assume that individuals are responsible for change. But if we look at that health equity population health approach, and we'll talk more about this in the next chapter, but we need to look at that social responsibility. So we need to assume that society must change. So again, those are things looking at those laws and policies to help, how do we improve the environment that individuals live, work, learn, and play in, to really focus on that population health approach. And a lot of that can come into play through that policy lens, what we're learning about in this class as well. So certainly opportunity to shift our current approach into more that health equity population health approach as well. We also want to look at influence of social determinants of health on health behavior and outcomes. So again, looking at that medical model, we know it's well accepted and respected by healthcare providers and researchers. It's widely viewed as grounded in hard science, reflecting truth about causes of disease. When we look at the population health model, it's less widely perceived as scientifically rigorous. Many are not aware of the magnitude and rigor of scientific evidence, underlying findings, or of the effectiveness of associated population level interventions. So there's certainly two different ways of thinking about that, but we know more and more by the research that's out there, even over the last 10 years, that the influence of social determinants of health on health behavior and outcomes is significant. So you'll see on your screen is a social determinants of health model and how it influences levels of influence on health outcomes in society and population health. Really looking at that individual lifestyle factors. Then we take into play those social and community networks. Then looking at where people live, work, learn, and play. So what are those conditions? Maybe they have, they're unemployed. Maybe they have poor housing. They don't have access to healthcare services. And so taking all those things into consideration is really important to understand those general socioeconomic, cultural, environmental conditions that impact and influence health outcomes. It's a complicated system, but it's certainly important to look at from that population health lens. So early research on health determinants was really based on epidemiological findings that were really linked in to that morbidity and mortality to socioeconomic status. You'll read about the White House study in your textbook, certainly a significant study that contributed to understanding factors that really contribute to those poor health outcomes. Mortality rates increase steadily with every reduction in status rank. A steady increase is known as a gradient in the population health model, but a dose response effect in the medical model. And then we also know that it's taken as evidence of a robust relationship between causal factor and outcomes when we look at the research on health determinants. Also research looking at the neighborhood effects, so that interaction of social and physical environmental determinants. So we've learned a lot about anymore with climate change, the effects of unsafe neighborhood, your environment that you live in. So anymore you may have heard that zip code determines our health outcomes. So that in a lot of ways is very true, and the research is supporting that as well. Also know predictive factors of life expectancy influence that health behavior and outcomes. So again, income, education, race and racial distribution, gender certainly are all predictive factors of life expectancy. The influence of social determinants on health behavior outcomes, we look at gradients within gradients when we talk about that from the population health model. You'll see how by race, how that impacts the percent of adults ages 25 to 74 years of age in less than very good health. And so you can see on your screen that those with less than a high school graduation degree tend to have poor health outcomes. You can certainly see that Hispanic population has the highest percentage of poor health outcomes across the races. But overwhelmingly, you'll see that as your education increases, your percentage of people in less than very good health decreases as well. So overall, this is data from 2009, 45.2% the U.S. overall who are in less than very good health. The national benchmark is at 19%. So moving along, we know that there's certainly issues with other influence of social determinants of health on health behavior and outcomes. So if we look at the percent of adults ages 25 to 7 years of age and less than very good health, and we also look at health-related behaviors and education, how they both affect health. So again, look on your slide. You look to the left of your graph. That less than high school graduate adults without healthy behaviors have poor health. Again, as education increases, you have adults in the blue have without healthy behaviors, and adults with healthy behaviors, even it gets better. So even college graduates still have unhealthy behaviors, but you'll see those with healthy behaviors and a college graduate tend to have a higher number of a percentage of those who are in good health. It's important to also look at from the other factors. We know in South Dakota, again, the University of South Dakota is based there, and certainly have a lot of rural communities. We look at the social determinants of health and those indicators. Rural counties tend to have high rates of premature death for many years, and the research supports that. Poverty tends to be higher in rural communities than urban areas. We also know that about 9%, almost 10% of the rural population has not completed high school. And we also know there tends to be a higher unemployment rate in rural communities versus urban areas. And so those are important things to think about from the social determinants of health perspectives and how that really does impact health outcomes and looking at those root causes. Some of the leading determinants of health is weighting the different domains. Important to understand, during the 20th century, medical care explained only 5 of the 30-year increase in life expectancy. Between 1950 and 1990, new therapies for infectious disease and heart disease were developed, but medical care accounted for only 3 of the 7 years of life expectancy increase. Medical care can be responsible for increasing mortality rates. For example, we could look at from medical errors, perhaps infection. Health behaviors such as smoking, physical activity, substance abuse, sexual activity, diet are considered major determinants of health in both the medical and population health models. And so the summary measures of mortality and morbidity tend to look at measures that summarize length and quality of life. When we weight these different domains to understand which one has more of an impact on health outcomes, one if you're not familiar with, it's called the County Health Rankings Report, and this has been around for quite a few years, but really what it does is ranks overall health of every county within each of the 50 states. This is a collaboration through the Robert Wood Johnson Foundation and Wisconsin Population Health Institute. It reports the contribution of multiple determinants of health on each county's overall health. They use a population health framework, really looking at health outcomes. They're viewed as a result of a combined set of factors also affected by conditions, policies, and programs in their communities. They really rankings are demonstrated by variation between one county and another in health outcomes, and then health determinants are the 2 areas that they look at: health outcomes and health determinants. And really back to what I mentioned earlier, that zip code determines our health outcomes, or where people live matters to their health. We also can integrate with that where people work, learn, and play also determines and matters to their health as well. So you'll see on your screen is the model that County Health Rankings uses. And really, again, looking at length of life and quality of life that impact health outcomes. They also look at health factors, how they impact those counties. And you'll see on your slide that health behaviors are 30% is what they've weighted that impacts our health outcomes, really looking at, again, tobacco use, diet and exercise, alcohol, drug use, sexual activity. Clinical care is only 20%. Of impact on those health outcomes, really looking at access to care and quality of care with that. And then, as I've mentioned earlier, we know that social and economic factors really are the largest driver in those health outcomes, and 40% really impact health outcomes. So again, looking at education, employment, income, a lack of or a presence of family or social support, community safety, certainly another one too. And then our physical environment is still important, but that's 10%. So looking at air and water quality, we may have poor housing, maybe a lack of transportation was certainly relevant in the rural community as well. But those add up to 100%, but you can see how those things really impact the health outcomes. This is just important to understand. In South Dakota, we have code 57108 is actually the highest income county in the state. Their life expectancy is 80 years of age. If we compare that to code 57623, which is actually one of the reservation communities in South Dakota, you'll see the life expectancy is 76.3. It's important to understand that because there's such a difference in health factors and health outcomes and what is impacting individuals' opportunity to live healthy. And so certainly have differences in wages, employment opportunities, different cultural issues or opportunities as well there too. So really important to understand how those social determinants of health impact health outcomes. Another way you can look at that too is what the new initiative through the Centers for Disease Control and Prevention, but they really understand how social determinants of health impact health outcomes. So they have what's called Health Impact in 5 Years, and I encourage you to go visit this website online. But you'll see how they're really focused on addressing those social determinants of health through policy. So really focusing on changing the context, so making the healthy choice easy choice, which you've probably heard that before as well. If you haven't, that's really the focus on policy. So for example, safe routes to school, maybe it's tobacco intervention, school-based programs to increase physical activity is really important as well. And really looking at long-lasting protective interventions, clinical interventions, and even counseling and education. But that high 5 or high health impact in 5 years is really looking at early childhood education, clean diesel bus fleets, for example. Maybe it's earned income tax credits, water fluoridation, and maybe it's looking at the public transportation system, but it's really looking at impacting those health outcomes and social determinants of health through policy. So really, we can understand that if we can address those social determinants of health, we have the opportunity to address and even perhaps achieve that health equity. So everybody has an equal opportunity to be healthy. And then ultimately that can really help improve our population health. And we'll talk more about this in the next chapter as well. These are some great tools that encourage you to go take a look at, but they really have an opportunity for you to understand the diverse number of data and factors out there that you can really understand how they impact health outcomes. There's a link to the county health rankings there. They also have some great information through the CDC Social Determinants of Health website. But I encourage you to take a look at these different websites to understand how they impact health outcomes. Also to understand how health policy is interrelated with return on investment. So we know that the U.S. expenditures on healthcare is two-thirds of it spent treating preventable diseases. Unfortunately, only 5% is spent on disease prevention, while 95% is spent on direct medical care. So understanding what you know now about the population health model, you can understand how there may be need to shift in policy to really focus more on that population health approach. And education versus medical services. We also look at health impact assessments, also to understand how community level prevention initiatives can really impact and support that return on investment. And hospitals also have to conduct an assessment of the communities that they serve, and they have to focus on how do they support the community and to benefit the health outcomes. So there's certainly a shift within that population health model. It's just maybe a little bit slower moving along, but that is certainly the direction that has to move, and certainly policy plays an important part of that, really looking to bridge the gap between public health and healthcare. Some opportunities to look at that are also through the ACA, or Affordable Care Act. We look at increased collaboration by hospitals and with public health community partners. A health dividend, certainly some work sites, and with that as well, giving employees dividends back for living healthy. We also know the Prevention and Public Health Fund is an important component that provide support for states and programs across the nation to really look at that prevention and public health perspective. We also have accountable care organizations looking at Medicaid waivers and even innovation grants to look at opportunities to be innovative, and how do we bridge that gap between healthcare and public health to really be innovative, to look at that population health model that really looks at improving health outcomes. And we know that healthcare sector is really beginning to screen patients for social determinants of health. Certainly a work in progress, but really looking at, while identifying a patient's social stressor may be relatively easy, putting into place a referral systems that are efficient and effective and generate feedback to the provider can be certainly can be challenging as well. So so they're moving in that direction, but certainly some opportunity to keep building off of what they're doing as well. So that is chapter 5, and you will also be learning from Susan Kroger, who will talk about the role that she's played within population health.